The American Rescue Plan Act of 2021 was signed into law on March 11th by President Biden. And what we're going through for us, there's a couple of sections to this, but for us, ours is section 9817. And what this did is this provided a temporary 10% increase to the federal match that we receive for services between the time of April 1st, 2021 to March 30th of 2022. That 10% was then we were able to get that money, and the state had to match that amount of money as well. So this money here is to be used to increase support. It's a supplement to the funds, and it's not to supplant the funds. And it's to be used in terms of the HCBS, which I got to make sure that I'm using all my acronyms for everybody, is our home and community-based waiver. That is what allows us to receive the reimbursement from the federal government. And that HCBS waiver is in lieu of institutions, and it's making it so that we move more towards community-based services. So this allowed us to have this this pot of money. And what CMS was strongly encouraging in terms of using that money was to expand eligibility for individuals, including those on the waiting list. It was to offer a broader range of community-based services. It was to make a long-term investment in the infrastructure in terms of capital investments to non-disability specific settings. The CMS has issued a settings rule, which is more community-based, and this is allowing states to help move them more towards those requirements. It promotes community integration. It strengthens the direct service workforce, and it also addresses the social determinants, those are the health and improve equity for older adults with people with disabilities. So that's what we were encouraged. We had a couple months to put this together. We had to work with our sister agency and our budget office. And so from that, we came up with our plan. And the plan starts off with helping in terms of enhancing the workforce and the stabilization of private providers. It was expanding access to and the use of assistive technology to promote independence, and while providing a cost-effective option that helps maintain quality and oversight of health and safety measures. It creates and implements an employment network for individuals who self-hire. We have one now, but it's a very watered down one and very minimal. So this will allow us to do a more robust employment network that will allow people who self-hire to match themselves up with staff that are looking for work. This is a short-term solution. The long-term solution is working with our state partner, Department of Social Services, where we will be creating a even more robust employment network that supports not just DDS's self-hired community, but also DSS's. And one of the options in here is to look at the possibility of setting up some kind of a backup system, emergency backup. So if an individual staff does not show up, is there a way of working through the employment network to have an emergency backup that would be able to be called to help assist parents and individuals? We're looking at expanding self-direction through the fiscal intermediary. We're expanding our supportive housing models. The system transformation, which is what I'm going to be getting into today. We have stability and infrastructure improvements that we have provided funding to providers to help assist them to strengthen their technology. We're looking at a comprehensive review of the universal assessment and the level of need groupings. The state has gone to a universal assessment, and DDS is now looking at how that would pertain to our individuals. We also have our level of need is also attached to funding, so we have to then look at how we would then attach our funding to the universal assessment as well. We're looking at a case management system, a new case management system. The one we have now, which we call e-cameras, is about 20 years old and not very flexible. So we're looking one that has universal modality, which will allow us to hopefully have providers and individuals and families be able to sign into the system so that they can see their individual plan, and providers could get access to authorizations. Another piece to this is we're looking at critical incident management system enhancements. So we have a system now that we've been working on, which looks at Medicare claims. So an individual may go into the hospital, and because they have Title 19, it's under Medicare. That individual, for example, let's say they have a head injury, what the critical incident management system will allow us to do is to, first off, was there a incident report that was done? Does that incident that happened at the hospital, does that rise to the level of a critical incident? We would then see, was the critical incident included? And if it was, did the system work in terms of having investigations and stuff? And if it didn't work, why wasn't why wasn't there a critical incident? We have a participant survey improvement, which is this is our national core indicator survey. We try to do every year, we do a survey of families and individuals to measure their success and any issues that they have. We've got that now tied to our Center for Medicaid and Medicare requirement, so that we then show them what improvements we've had and whether there's issues that we need to work on. And then the last piece is the creation of an outcome-based incentive program. So we're looking at, there's movement now that providers would get paid based on outcomes. And so we want to see what's out there in terms of other states. What if we were to move in that system, how would that work? And how would we be able to set that up? So we would be looking at hiring a consultant to help us do that. So that's what our DDS approved plan for the whole ARPA initiative is. What we're going to be getting into now is transformation. And so what is meant by transformational change is a complete change in an organization designed to bring big improvements. So this is supposed to be in a pretty big scale. Now, that's easier said than done when you're talking about individuals, and so you need to make sure that whatever change you're doing is in the best interest of the individuals. And so we're looking at how do we do this in a way that increases people's independence and choice and being more in the community. So why does DDS need to change? Well, some of the lessons we learned from the pandemic, the congregate settings, because of the nature of the pandemic, we had to close day programs. We had to restrict visitors from going in and out of group homes. Those kind of settings, once one person got it, it was very difficult to contain. So what we found is that, you know, the more independent settings had less, they were still subjected to the virus, obviously, but there was less transmission because they were more spread out. We also know that there's a staffing crisis. There's a staffing crisis throughout the whole country, you know, and we understand that. We also realize we don't know where this is going. We don't know if this is a temporary thing or this is a long-term thing. We do know we have a number of staff now. And so one of the things that we need to look at is how do we use the staffing we have in a much more efficient and effective manner. There's also been the advance of technology. A lot of assistive technologies out there that we have started using, not on a grand scale, which we think will be beneficial to individuals. And so that's kind of what we'll be looking at as well, is how do we use the technology to assist us in terms of moving to more community-based settings. We have a waiting list that has been pretty stable. So we need to figure out, as we move from more congregate settings to less congregate settings, how do we then provide more supports to individuals who are on the waiting list? And then lastly is sustainability. When you look at congregate settings, they're obviously the most they're the most costly. And so especially with a group home, you have staffing that the staffing is on a permanent basis. There's always shifts that need to be filled. And so we're looking at how do we try to figure out programs that are more sustainable in terms of the resources we have. So what was approved through the American Rescue Plan in terms of the transformation is a multi-pronged approach that includes 4 initiatives to meet the goal of transforming from both residential and day supports away from congregate settings towards more integrated and efficient settings. And those settings should promote independence and freedom of choice. These dollars that we're receiving are not annualized, so they are one-time dollars that we have. We have been approved by the legislature for FY23 and FY24. The money has been allocated over 2 years. Recently, CMS has extended the deadline for an additional year. While we believe some of those supports we can be reimbursed into the 3rd year, we're trying to move that. We're trying to do this within those 2 budgeted years. So our last date of service would go through June 30th, 2024. If everybody can put their on mute, please. Thanks. As I said, the legislative gives us approval for 2 years, and so we want to make sure that we maximize the money that we have for those 2 years. If at some point there's some ability to move forward, we would take a look at that. But right now, our goal is to get this moving and through June 30th of 2024. So what are these initiatives? So the first initiative is to develop an incentive payment program to encourage providers to consolidate current vacancies in congregate settings. And as they do that, how do we redistribute some of those savings to individuals who are on our waiting list? The second initiative is it focuses on stability. So as more people move out of one setting and they start moving towards another, we have to make sure that setting that they're moving from is stable. And so we'll be setting up incentives and payments that will help to maintain fiscal stability in those programs while we move individuals to more cost-effective supports. And at the same time, we'll be looking at enhancing the rates of those providers who are establishing new programs or new places for individuals to go. to make sure that there's a transition and there's adequate resources to help ease the individual into those new sites. The third part of this initiative is to contract with consultants. So what we're looking at is a consultant to help us train, facilitate, and assist our providers to develop transformation plans. So we're trying to work with providers as part of those plans. How do we engage in all the different stakeholders to make sure that everybody understands what's happening, what's best for the individual. Another piece to this is we're contracting with a communications consultant group that will help us in terms of the message that we want to send out to providers, to families, to DDS staff, that it's a consistent message, that it's in the modality that best meets the needs of the people. And how that we do that in a simple and a clear way that shows that what we're trying to do is promote independence, integration, and employment-based services. The fourth initiative is setting up an outcome-based payment program, and we're having consultants that are going to come in. We'll be working with DDS. They'll be reviewing other states in terms of what have other states done in terms of identifying an outcome-based payment program and looking at the DDS metrics, the data we have here, so that whatever we set up, we'll be able to make sure that we can measure accurately to determine whether an incentive, an outcome has been achieved or not. And what we want to make sure that this is a marathon, it's not a sprint. And while we have 2 years to do this, what we're looking at is to make sure that that we provide the base in these 2 years as people move forward. We don't want to force people to move too quickly. We don't want people to stall the process either. But we think that providers and individuals will need to be moving on in their own timeline. And some journeys are going to go quicker than others. And we just have to make sure that as we move forward with this, everybody's moving at that pace that's best meets them. And so, while we have 2 years here, we have to figure out how do we sustain this moving forward. So what could transformational change look like for an agency? So for an agency, it could look at a reduction in the number of group home it operates. It could look at some of the homes may right now be more suited to individuals who have less behavioral and support needs. And so what this would be able to do is to provide resources to start redesigning some of those homes that they're vacating to be able to support individuals with more medical and behavioral support needs. We're looking at increasing in alternative individual settings for people currently in their program or on the waiting list. This would include supportive housing. Supportive housing has been a growing piece for DDS. It's individuals and living in an apartment setting, and the apartment setting has identified apartments that are designated just for people with ID. There's usually a staff that is living at the site to provide supports to the individuals. So there's overnight staff. We're looking at remote supports for individuals who are able to live on their own but may need assistance, but they don't want direct staff there. This allows staff to be virtual, and the individual can call upon that staff at any time. And there's actually direct care staff on the other line on the computer who knows their program's been trained with their program, can assist them in terms of issues they may have, meal planning, ADL, and all that kind of stuff. And of course, there's an emergency backup plan to all those. And then there's an increased use of assistive technology. And we want to make sure people understand what transformational change does not mean. It does not mean there will be no more group homes. We feel that at this point in time, there's still a need for group homes. We just don't know what the actual number should be. I think personally, I think we have too many group homes right now, but I don't know what the right number of group homes should be. Providers will be forced to close all congregate day settings. That's not what we're saying here. We know that there's individuals who can benefit still from congregate day settings. Once again, we need to make sure that individuals who are in those settings want to be in those settings and are given all the chance and opportunity to work and be in the community. After this, there'll be no more waiting list. That's just not realistic. There's people coming every day looking for services. So what we need to do is try to figure out a way that we work through the list in a more efficient manner so that people aren't waiting for many, many years for services. And that lastly, and staff will be replaced by assistive technology. That's not the goal of this. I think, as I said, we need to be able to use staff more effectively. And in some cases, assistive technology can assist with that. For example, well, there are beds at this point that automatically reposition an individual. So if an individual needs to be repositioned at night, what happens now is usually a staff goes in there and has to help the individual to reposition. Whereas these type of beds automatically do it. They go up and down and do that so that the staff doesn't have to go in there and interrupt the person's sleep. It just happens automatically overnight. So those are the kind of things that we're looking at. How do we enhance what the staff can do versus replace them? So what are our expected outcomes? So our goal at this point is 100 individuals will move on from a congregate setting in residential and into a more independent setting. Our goal is that 200 individuals will move on from a congregate setting in day to a more community-based setting. So what does that mean in terms of what are these examples of residential transformational change? So these are the moves that lead. There could be moves that lead to closing a setting, moving to an individualized home support, which is people living in their own apartment on their own. They could be moving to an IHS setting with remote supports. So they have the apartment is wired, and if they need assistance, they can call upon that whenever they need assistance. There's clustered IHS where individuals live in a variety of settings in a small area, and there's a staff that's available to them overnight, usually between 11 and 7. There's cluster IHS also has technology that they incorporated the technology in order to maybe stretch out how far that staff can travel. Moving to one's home, apartment, or family home using electronic face-to-face. Sometimes it just needs, some support from a provider or a staff. Well, if he's doing this, this is what you need to do. Sometimes we can also set those same places up with remote supports and have them all wired. It'd be moving into a CCH, which is a community companion home. This is a family who has opted to have an individual live in their home with them, and they become part of their family. It could be moving to a self-direct their residential supports. So individuals who currently are in a congregate setting would be able to use their money and self-direct their supports. And lastly is moving individuals who have significant behavior or medical supports off the emergency list and into a vacant bed of a CLA or CRS. So as the individuals move out, they're looking at people who are on our emergency list that need more significant supports, would be able to backfill into those positions, those homes. And then when we're talking about day, what do we mean by day? It could be a day support option, which is a day congregate setting in the facility, and they could be moving to a GSE. A GSE is a group supported employment program, which is usually like a mobile crew. There's less people in it, usually 5 or 6, that do a task with a supervisor, and that they go from a DSO to full-time ISE. ISE is for individualized supported employment, so that's into their own job. And that looking for their own job could be through a regular job coach or through what we call customized employment, which is a little bit more intense in terms of supports to help assist individuals find the job that best meets their needs. It could be for part-time programs, so they could go from part-time ISE and part-time GSE, go to straight to competitive employment. They could go to an individualized day program. It could also be somebody moving from one of those group supported employment to their own job, to an ISE, or a part-time ISE job. Could be part-time to full-time. They could have a part-time job and then go into full-time individually supported employment. It could be going to self-determination, so they're decided to self-determine their own resources. It could be we have transition services, which helps individuals move through a number of business opportunities, and the goal for that is competitive employment. And then the last is it could be to a project search program. And the project search is a program that's embedded within an industry. For example, we have one at Goodwin College. We have one that's at Yukon Health Medical Center. And in there, there's a variety of jobs that they do, and they have education component too. And so they're constantly rotating and being trained in terms of the work that they're doing, and also helping them to understand the work skills that they need to move forward. So as we look through that, some of the pieces that the committees will be looking at, especially the 2 working committees, will be looking at what are these incentives. And so we're calling one of them the moving on incentive. And what that is as the provider develops a transformational plan, and they've decided they have, and I'll use an example of a group home that has 4 individuals in it. And right now there's a vacancy there, so maybe they have 3 individuals, and they've decided that they want to close that group home, and they believe the individuals in there can receive supports more independently in the community. So as each person moves out, they would receive an incentive payment as each one moves out, usually after 60 days, to make sure that there's a success to this. As that person's moving out, now you're down to 2 people. DDS would be working with a transition incentive, so that the individuals that are still there, their reimbursement would be higher, to make sure that the same staff are there, so that we're not putting that home in jeopardy as it works its way through the transition. And then as those people move to a new placement, whichever agency they go, and it doesn't necessarily have to be the same agency, it probably will be. But for example, if an individual wants to go to a CCH, a community companion home, that they may end up, what they want to do is to move to move to another agency. So that agency, and that could be part of the transformation plan for the provider with the the CLA, the group home. So when that person does move to that new placement, at that point, they would receive an incentive payment. For example, it could be 2 times the hourly rate that they're receiving now for a period of time in order to help them with the transition to make that a little smoother for them. And what would the day incentives look like? Once again, we have a provider transition incentive. So as individuals are moving out, we would make sure that the time period of the transition that we would be supporting that provider as each person moves out. So we would be making sure that the funding would still be there to provide stability and consistency in that program as the transition happens. If the place is a new group home, is the placement's a new group supported employment setting, we would be looking at giving them their current rate and probably another rate above that to assist with the transition. And as more of an incentive, if an individual wants to go into individualized employment, at that point, we're looking at giving them a rate that may be even more than that. So they could be getting twice as much or 3 times as much as the rate. This will allow to help in terms of the staffing and the job placement piece to it. So providers will be working through transformational plans. And once again, as we work through this, the teams will be, the committees will be looking at this because we want to make sure that there's a couple of pieces to this. So first off, we need to know what their current services are. How are they currently structured? What do they do? Where do they want to go? What's their future configuration? If they want to move, if they want to develop a supportive housing unit, how does that going to work? And how would they be able to use the staffing? Would they use the staffing from some of the existing places as they transition from congregate settings? We'd be looking at a gap analysis. So if they want to go from here to there, what's the gap in analysis in terms of what do they need to make sure that they get to that point? As if they're going from, if they're looking at converting one of their homes to provide more medical supports, what are the support needs that they will need in terms of clinical supports? They'll need clinical supports and nursing and all that stuff. How will that work and what will they need? We would need to make sure there's a sustainability plan. So it's great. We don't want people to say, okay, we're going to move everybody here and then come to find out it doesn't work. They can't support with the funding that's available. So we need to make sure that as part of the transformational plans that there's sustainability plan as to how they're going to keep this funding going once all their incentives have stopped being given. And lastly, we want to make sure that there's communication and engagement of the various stakeholders. So how are they going to communicate what's happening and how do they engage in those with the stakeholders in terms of what they need and what their hopes and aspirations are. So we have these working committees and you guys are all part of this. We have the advisory committee to start, and the advisory committee is overseeing the transformational intent of what we're trying to do. So they're looking at gathering input and feedback from them. We need to make sure that its focus is still is effective and positive, consistent communication to all the stakeholders. It's going to be looking at what all the teams are coming through and making sure that all this on a macro level, that all is working the way that we think it should. The residential and day transformation process teams, these are what I call the working committees. They'll be receiving, to start off with is the incentives. and looking at that and saying, you know, how does that work? How is it? Do those incentives seem to me the right ones that will help individuals move forward? We'll, because of the timing of all this, we'll be providing the two committees with drafts and having them react to those drafts. Not that we won't accept any of individuals' um, uh, options or ideas. It's more that we're trying to get this thing moving forward. We really don't have time to do a brainstorming piece that goes on and on and on, and then you know, we won't get anything for months down the road. So, you know, we're trying to see if how much we can focus this to make sure that this is providing direction as in an efficient and effective manner. And then the two engagement committees is how do we engage with the individual and family um, units? One of the things that DDS struggles with is how do we communicate consistently across the board to all our individuals and families. You know, we go through our case managers who do a great job, but sometimes the message, sometimes it's like telephone, gets a little changed as it goes from one supervisor to the case manager to the family. So we're trying to figure out how do we do it more consistently, and how do we do it so that it's in a message that's clear and concise, that's person-centered, that is done based on the language of the individuals. So, you know, they'll be using information that's going to come out of the day and transformational committees. But in the beginning, they'll be looking at, you know, what's the house, what is the how, you know, how are we going to do this? Probably there'll be some education to that group in terms of all the different options, so everybody understands what those options. They'll also be working with the communications consultant to help in terms of make sure that our message is on point and clear and concise. And then the DDS Engagement Committee, this group will work to assist central office in developing consistent communication for all DDS staff. I think, you know, we have done initiatives in the past, and sometimes we've done it where we haven't been as consistent through all the different groups. And so we may be more consistent with the providers, but we did not do a good job with the families. And sometimes we've done a good job with the families and the providers, but not with our own staff. This one, we're trying to make sure that we cover all the bases, that everybody knows which way we're going, why we're doing it, what this involves, and how do we make sure that this is a success. There's going to be a lot of attention onto this. There's a lot of money that's involved, and so we need to make sure we have all our ducks in the row. So one of the things that for the committees here, um, the goal is to utilize the funding to help providers begin to transform their programs to more efficient and individualized settings at the rates for those settings in July of 2024. So this is basically a little less than 2 years, which means we don't have a lot of time. And one of the things that we've told the co-chairs is that their priority is to keep their specific committees on track and on time. There's not, I don't think anybody wants to go to a committee that is not being um, to, successful. And so the co-chairs need to make sure that, you know, their goals and their objectives, that they're going to be moving forward and helping to move the process. And so so not to thwart people's creativity, I just think people need to understand that there is a time period to this. And so what are the committee expectations? It's to help keep this initiative moving forward. We want to make sure all members attend all the meetings. I know it's not easy. Attend as many as you can. If you think you're not going to be able to attend most of the meetings, I'd ask you to reevaluate whether this is going to be successful for you. As I said, timing is important, that we can't be rehashing what happened 2 meetings ago because somebody missed something. So we really need to make sure that attendance is, that you're attending the meetings as much as possible. We ask you to study the agenda prior to the meetings. The agendas, as I said, will be on our website. We want you to stick to the agenda. Discuss the new business only at the appropriate times, so go through the agenda, make sure everybody's doing what needs to be done. Keep replies short and to the point. We know people come in and sometimes they have something on their mind that happened to their loved one, and that may not be the right place to be discussing that. If you feel that's an issue, you may want to talk to the co-chair as to how best to resolve that, and we can work through that. Sum up the remarks of a lengthy discussion. So at the end of your remarks is like, basically, this is what we're looking at doing. And make comments at appropriate time if you disagree with the speaker. This isn't to thwart people having a good conversation. We just want to make sure things are appropriate. And I say that because all these meetings will be recorded. And so anybody at any time could go in and listen to the committees. And, we want to make sure that the people are speaking appropriately, even if you disagree with the speaker. So here are the things that come with the public meeting requirements. So there needs to be a meeting notice, no less than 48 hours before the scheduled meeting. The agenda needs to be on the DDS website no less than 24 hours before the meeting. The Teams invite needs to be there no less than 48 hours. And then the minutes are to be posted no more than 7 days after the scheduled meeting. So that's why we set up the website. And so the co-chairs will be working with Keith, myself, and Greg to make sure that these are posted in a timely manner. So if ever you want to see what's happening or need to know what happened at a meeting that you couldn't attend, they're all will be posted so you can go back and read those. And the other piece to this is, as people are talking, and it's going to be a little awkward for people, I know it's been awkward for me, is when you're in a dialogue and you're going back and forth and each person is putting in their comments, you need to make a good faith effort to state your name and your title. And because if people are just hearing this, they won't know who's talking. So, and the co-chairs will try to keep reminding people, you have to try to make a good faith effort to state your name and your title every time that you go to make a comment. And this is all part of a public law, so there's very little leeway for us. If we were meeting in person, then that's a whole lot easier. Most of our meetings will be done, they'll be done virtually. So because it's virtually, there's some more restrictions on it. If we had a meeting in a conference room, then it would be, you can, as a public person, you can show up and listen, and then we didn't have to do anything. But because this is virtually, we have a couple more restrictions on us. And then the public meeting decorum. So what we've tried to say that is, if a meeting is interrupted by any person or groups of person that start to have a disorderly conduct to it, so the co-chair will try to redirect people. And if it gets to the point where, it becomes a little bit more confrontational and The decorum seems to not be where it should be. The co-chairs have the option of terminating the meeting and rescheduling. I don't think we're going to get to that point. I just think that at this point I need to state some of that stuff, just so that people understand, we're in a different world when we have to record everything, and anybody can go in and listen to those recordings. So the next steps, the co-chairs will be reaching out to each of the members to set up a meeting sometime over the last 2 weeks of August. And at that meeting, they will establish a meeting schedule for the next 2 months. And we say that so that they'll set it up. And once we set it up, we then can have established the same invite for the meeting. So we can get that narrowed down, and that can be put on the website. Every time we have to change it, it's a different address. So that's why we're looking at if we can schedule it for the next 2 months.